So hello everyone, and good to see you all. Good to see everyone, and congratulations to those who are accepted to the residency. So today we will have a good meeting, and we have good news. So I think the team will run the meeting is a brown team. Sarah, are you going to?
Yes, I'm the moderator here.
Okay, thank you.
Thank you, Dr. Nader. First of all, I would like to congratulate all our colleagues who matched, and our colleagues who couldn't make it this year. Please hang in there, keep your hard work, and inshallah you will match. Bismillah. Also, I would like to thank Dr. Nader for his efforts and help and mentorship over the last year. It made the whole difference to me personally, like 180 difference from being a repeat applicant multiple times to matching this year. Alhamdulillah, and thank you, Dr. Nader, for all your efforts with us. And with that, I would like to start our agenda for today. So we'll start by Dr. Avinash will start reviewing with us the topic about osteoporosis, and then Dr. Azza will present reaching out to programs after the match and SOAP. And then we will discuss the basics of evidence-based medicine. The PowerPoint was done by Ala Abdul Samad. And then we will have an open discussion about the experiences for those who matched, would like to share their experiences for the match for our colleagues to be ready for the next cycle in a good shape. And that's it. And so now I'll give Dr. Avinash. Are you ready?
Yes, I'm ready.
Okay, let's go ahead. Okay, thank you.
Thank you so much, Sarah. Let me share my screen. Is it shown to everyone, my screen?
Yes, I can see it.
Okay. Thank you so much, Dr. Nader, for giving me an opportunity for this presentation. Today, my topic is osteoporosis. Okay, so our objective is to how to diagnose the osteopenia and osteoporosis, and what is the pathogenesis of osteoporosis, what are the causes, and which is a tool we use to predict the fracture risk, and what are the prevention and treatment strategies for the osteoporosis. Okay, so the definition of osteoporosis is actually the most common metabolic bone disease, and it is the major cause of morbidity, loss of independence, and mortality in older adults. It is actually a systemic skeletal disorder defined by the decreased bone strength, density, and quality with an increased risk of fracture. And it is a silent disease that requires clinical monitoring for the risk factors and active screening. And once the osteoporosis is diagnosed, multiple treatment options we have to reduce the risk of the fracture. And on the basis of bone mineral density, the bone mineral density measurement at any site less than -2.5 standard deviation below the young adult standard, with or without previous fracture. So a T-score of -2.5 or lower indicate that the patient have a osteoporosis. The greater the negative number, like -3.5, -4.5, the more severe is the osteoporosis. The primary osteoporosis is age-related, which most commonly occur in old age, while the secondary osteoporosis, we have many causes, either the nutritional causes or the deficiency of the vitamin or medications, and we will discuss it one by one. Okay, osteopenia can be defined as low bone mass, and the T-score less than -1, but greater than or equal to -2.5. Once it more -3.5, it will be goes to the osteoporosis. Epidemiology. The osteoporosis affects the people of all ethnic background, and the 2 million osteoporotic fractures in US annually, while 1 in 2 post-menopausal women and 1 in 5 men who are more than 50 years old will have a fracture in their lifetime. Bone remodeling. It is a process in which the bone formation and bone resorption occurs. There are two types of cells. One is osteoblast and one is osteoclast. Osteoblast is responsible for the bone formation, and the osteoclast is responsible for the bone resorption. The remodeling cycle may become unbalanced after menopause or with aging in men and women. The bone resorption increases more than the bone formation, resulting in the bone loss. So first bone loss causes osteopenia, then osteoporosis, and the end result it causes fractures. There are many risk factors for the osteoporosis, intrinsic, genetic, external, and we will discuss it one by one. So the most common risk factor for the osteoporosis is estrogen deficiency, which leads to bone loss by the increased resorption and increased osteoclastic activity. Actually, after the menopause, the natural decline of the estrogen level is associated with increased risk of osteoporosis and a fracture. And increased resorption appears to be the major factor for the bone loss in estrogen deficiency. And evidence also suggests that the role of estrogen deficiency in reducing the bone formation over time. Sex hormone imbalance in the men, severe hypogonadism in men, either due to pituitary tumor or due to androgen deprivation treatment, like in the prostate cancer, the medication we have used, it causes the osteoporosis. And also in men, the bioavailable testosterone and estrogen decreases with aging, mainly due to the increase in the sex hormone binding globulin, which lead to the decrease in the bioavailable testosterone. And approximately half of the men who are more than 70 years old have low testosterone levels below the normal reference range. And several studies suggested that the late onset hypogonadism play a major role in the osteoporosis in men. Another risk factor for the osteoporosis is the insufficient skeletal loading. For example, the person who is not doing the exercise is the major risk factor for the osteoporosis. And vitamin D insufficiency and calcium, this is also the most important risk factor. And with aging, the intestinal absorption of the calcium declines, and the vitamin D play a main role in regulating the calcium. And the hormonally active form of vitamin D, that is calcitriol, is necessary for the intestinal absorption of calcium and phosphorus. And it also exerts its inhibitory effect on the parathyroid hormone. So what happened in the aging skin, there are decreased sunlight exposure, resulting in decreased conversion of the 7-dehydrocholesterol to the active form of vitamin D, resulting in vitamin D insufficiency. And insufficiency causes decreased calcium absorption. Older Black Americans are at a particular risk of vitamin D deficiency as they age. And older adults have less ability to absorb the calcium from the intestine. Okay, now let's discuss the extrinsic factor, the smoking and alcohol. Smoking actually increases the risk of fracture in both current and former smoker. And alcohol, like drinking more than 3 ounces of alcohol per day, early or later in life, resulting in bone loss and fracture risk. How to diagnose the fracture? So the osteoporosis is actually a preventable disease, but it is often not diagnosed until the fracture occurs. So the National Osteoporosis Foundation recommend the clinical assessment of the osteoporosis risk factor for all postmenopausal women and men who are more than 50 years old. The diagnosis of the osteoporosis should be considered in any older adult with a fracture. The risk of osteoporosis, preventable risk of osteoporosis, like the exercise, we have to encourage the patients to do the regular weight-bearing exercise at least 5 times per week for 30 minutes. And nutrition, encourage them to take adequate intake of calcium, 1200 milligram per day in divided dose, and vitamin D3 800 to 1,000 international units per day, and also educate them to smoking cessation and avoid excessive alcohol consumption. There are modifiable risk factors by which we can reduce the risk of osteoporosis, like the medications, glucocorticoid. Medications is an important secondary cause of the osteoporosis, the glucocorticoid being the most culprit in men and women that causes the glucocorticoid-induced osteoporosis, which causes increased bone resorption. And while evaluating the patient for the osteoporosis, clinicians should also remember to consider the medications that increase the risk of fall, like SSRI, all these things. Okay. Other common causes are the secondary causes of osteoporosis are the male hypogonadism, excessive alcohol use, vitamin D deficiency, malabsorption like celiac disease, multiple myeloma, all these things. So the initial laboratory testings which are required or recommended for the diagnosis of the osteoporosis are the fasting comprehensive metabolic panel, serum phosphorus, vitamin D, or we can say K25-hydroxy vitamin D concentration, serum parathyroid hormone, thyrotropin, and urine collection for the calcium and creatinine, CBC, and testosterone. Clinical evaluation. When the patients come to the clinic, how we can evaluate, like the patient have a fracture or osteoporosis or not. So to take a thorough history to uncover the risk factors that may lead to the bone fragility, and important to understand the setting in which the fracture occurred, either the excessive usage or in the setting, all these things. So in which setting the fracture occurred, it is very important. And the physical examination is also directed toward the detecting the signs of fracture as well as assessing for the secondary causes. Clinical evaluation laboratory by checking the vitamin D level, by measure the bone density, while the use of biochemical marker in the clinical practice is controversial. Bone density measurement, we can check the bone density measurement with the help of DEXA scan. It is a dual energy X-ray absorptiometry, which give us a prediction about the patient's is at a fracture risk or not. Bone density measurement. The United States Preventive Services Task Force recommend the DEXA in the main 50 to 69 years old with disease or the medication known to increase the risk of osteoporosis, and in those with a history of fracture after age 50. And while in the women, the testing for all the women who are more than 65 years old, regardless of the risk factor status. And if the woman is less than 65 years old, should be screened if their 10-year fracture risk is equal to or greater than of a 65-year-old white woman without additional risk factor. While there's another foundation, National Osteoporosis Foundation, who recommended screening all men for more than 70 years old, regardless of the risk factor. FREX. It is actually a free online tool. It requires some data by we can put it in together in the online, and it will give an idea about the fracture risk, probability of the fracture of a 10-year in the men and women. And the data is used to calculate the risk is include the femoral neck bone mineral density, patient's age, patient sex, height, and weight. And other 7 clinical risk factors include the previous fracture, parental history of the fracture, current smoking, glucocorticoid use, rheumatoid arthritis, and secondary osteoporosis, and the alcohol consumption. But the drawback of this tool is that it is not valid if the patient's age is less than 40 or more than 90 years old. And this tool is limited to the 4 ethnicities: white, black, Hispanic, and older. And if the patient have any femoral neck osteopenia or fracture, it will not give you accurate result. So these are the drawbacks of this tool. Some biochemical markers we can check in case of osteoporosis, like these two biomarkers, deoxypyridinoline cross-linked type 1 collagen and cross-linked antellopeptide, which are increased, which show that the bone have an increased resorption activity. The bone is degrading osteoporosis. So these levels will be high in the osteoporosis, while the bone formation marker, the bone alkaline phosphatase, it means the bone is making more, like in the case of Paget disease, we have a thicker bone, and in which condition the osteoblast activity is increased, that cause the more bone formation and the increased alkaline phosphatase. Okay, and whom to treat? The post-menopausal women and men who are 50 years old who meet the criteria for osteoporosis by the DEXA or have a history of hip, vertebral, or prior fragility fracture. So in patients whom treatment is being considered, the secondary cause should be evaluated and excluded as well. All patients should have adequate calcium and vitamin D intake, engage in the regular weight-bearing exercise, encourage them to avoid excessive alcohol and tobacco products, and counsel them regarding the falls. Okay, how to prevent the osteoporosis? Again, the exercise, intake of calcium and vitamin D, and some pharmacological options we have available. We will discuss it one by one. While the weight bearing and muscle strengthening exercise are the important component of the osteoporosis treatment and prevention, exercise alone is insufficient to prevent the rapid bone loss, which is associated with estrogen deficiency in early menopause. So weight-bearing exercise such as walking can be recommended for all adults, while the older adults should be encouraged to start slowly and gradually increase the amount of time as well as the number of the days spent walking. Okay, the WHO recommended requirements of the calcium and vitamin D. So the postmenopausal women who are more than 50 years old and the men who are more than 70 years old they need 1200 milligram per day of the elemental calcium, while the men 51 to 70 years old require 1000 milligram per day elemental calcium, while the upper intake for all the group is 2000 milligram per day. And the vitamin D requirements is the men and women 51 to 70 years old require 600 international unit per day, and who are more than 70 years old need 800 international units per day, while the upper intake for all group is 400 international units per day. All patients should limit the vitamin D intake less than 400, and our goal is to achieve vitamin D concentration more than 30 nanogram per milliliter. Okay, again, there are two terms, vitamin D insufficiency, vitamin D deficiency. Vitamin D insufficiency when we have the 25 hydroxy vitamin D level between 21 and 29. And if it is less than 20, it is vitamin D deficiency. And our goal should be to maintain the vitamin D concentration of more than 30 nanogram per ml. Now let's discuss the treatments. Bisphosphonates, which are approved for the osteoporosis prevention in a postmenopausal woman and for the treatment in men and women. It increases the bone mineral density and decreases the fracture risk at the spine and hip. There are many side effects of the bisphosphonates, but the most common, which is concerning, is the pill-induced esophagitis and the osteonecrosis of the jaw and the atypical fractures. Let's discuss the pill-induced esophagitis. So whenever we recommend these drugs to the patient who have osteoporosis, we should counsel the patient to take this medicine first things in the morning before eating or drinking anything else. Take at least 8 ounces of plain tap water and take this medication while upright in a chair or standing and remain upright for 30 minutes after ingestion. Do not lie down or sleep after taking these medications. And with alendronate and resindronate, do not eat or drink anything for 30 minutes after ingestion. The esophagitis is particularly, it causes the erosive esophagitis, causes ulceration, and it is most commonly in patients who do not take the medications properly. So they should have to remain upright for the 30 minutes after administration. As the absorption of the oral bisphosphonate is very poor, so it is extremely important for these patients to follow the specific and detailed instructions for taking them. And who the patients taking bisphosphonates are encouraged to report new groin or the thigh pain to their healthcare provider. Because such pain is reported, radiograph of the both femurs should be obtained because these medications can cause atypical fractures. So we had to counsel that patient. Okay. We have another drug, selective estrogen receptor modulator. These drugs act as estrogen agonist in the bone and heart, and they act as an antagonist, estrogen antagonist in the breast and uterine tissue. So it is a potential for preventing the osteoporosis or cardiovascular disease without increase the risk of breast or uterine cancer. So raloxifene, it is approved for the osteoporosis prevention and treatment in postmenopausal women. Dose is 60 milligram per day. And it is also approved for the breast cancer prevention. Calcitonin, it is a hormonal inhibitor of the bone resorption. While the FDA recommended against the use of this calcitonin to treat the osteoporosis in postmenopausal women because of the potential increased risk of breast cancer. Estrogen replacement. Estrogen actually prevents the bone loss at the hip and spine when initiated within the 10 years of menopause, but it is not recommended as the first line choice for the osteoporosis. Parathyroid hormone, which increase the bone formation and resorption, but it is typically reserved for those who have a severe osteoporosis and fracture history. But again, there's a black box warning. It is contraindicated in patients with Paget disease or who have a history of skeletal radiation. But this parathyroid hormone is preferred treatment for the glucocorticoid-induced osteoporosis. Denosumab. It is a monoclonal, human monoclonal antibody that inhibit the rank L. These things are present on the osteoclast, which increase the activity when this rank L bind to the rank L on the osteoclast, it causes the increase the bone resorption. So we had to inhibit that factor, the receptor activator for nuclear factor kappa bind ligand, resulting in inhibit the osteoclast, reduce bone turnover, and increase bone mineral density. And FDA approved this for the postmenopausal women at high risk for fracture or who have failed or intolerant to other therapies like bisphosphonates, all these things. Strontium, it is an anabolic agent. It acts via increased bone formation, decreased bone resorption, but it is not approved in the US. Our next topic is vertebral compression fractures. These are actually asymptomatic. Majority are the asymptomatic, but some causes the pain. We can diagnose this case incidentally by the spinal radiograph, resulting in the increased kyphosis or decreased height, or the cloths may not fit properly over the time. And the chronic back pain occurs due to spinal changes that occurs with the vertebral compression. How to manage the vertebral fracture? First of all, treat the pain which is associated with the vertebral fracture because it interferes with the activity of the daily lives and the quality of the life regardless of the cause. We can treat with medication, NSAID, calcitonin, narcotics, and the physical therapy like postural exercise. It is very important for this in this case. And educate the patient, support groups. The other advanced treatment are the vertebroplasty and kyphoplasty. So these are the options for the vertebral compression fractures treatment. Thank you very much. If anyone have a question, can ask, please.
Okay, thank you so much, Avinash, for your detailed and in-depth review of osteoporosis. It has been very wonderful. Great job. Thank you so much.
Thank you.
Okay, I don't see anyone who has questions. Maybe we can proceed with the next section in our agenda. So, Dr. Azza, she is volunteering for us from the Blue team to discuss with us how to reach programs after match and the SOAP. So thank you so much, Azza, for joining us today. And please go ahead if you're ready. Thank you.
You're welcome. Thank you, Sarah, and thank you, Avinash, for the great presentation. First, I would like to have a big congratulations for all of our fellows who has matched this year. From the first batch, Lubaba, Sumi, Ali, Dr. Muhammad Saleh, and from the second batch is Sarah, Krupa, Dr. Ali, and who else? Hiba. Please remind me if you. So you did all great job, and Sarah, yes, big congratulations for everyone. You all did great job, and congratulations for your hard work, and congratulations also to Dr. Nader. He's been a great help and support throughout the whole process. And wishing everyone else who hasn't matched this year, hopefully he will match and they will match into their programs next year. And this is stay positive. I know it's hard. I know it's challenging. I don't want to say don't give up, because of course you're not giving up. You are giving it your best. Someday it will all work out and for the best, as long as you are going through you are going through this line. So first of all, I know, we all know that Shayma, congratulations, Shayma, congratulations. And okay, so after the SOAP, you know that during the SOAP, we are not allowed to contact the programs. So after the SOAP, if you have the list of the unfilled, there is a list for unfilled positions in a program. You can contact the program either by phone or an email, or if you know someone in that program, that will be a great help too. So first thing is, just when you send an email, make sure that you have a standard template, plus you are sending your CV as well. So make a brief CV, short brief CV, is preferably like 1-page CV. And in your email, when you are sending the email, also tell a brief about yourself and why you want this position in this program. A lot of programs don't say they have an unfilled position after the SOAP. They don't say, they don't mention it, but maybe someone working inside the program or someone within the program will know that they have it. So this is a good opportunity to send an email, to call and present yourself. And hopefully you will get an interview for that position. And also there is really good websites like Find a Resident or Resident Swap. I had an account with this website last year. You will set your like credentials, your year for graduation, your visa status, and they will send you an alert email if any of the program in your specialty, like if you're applying to internal medicine or family medicine, they will send you an email to alert you that there is a position open in this program, like PGY1 or PGY2, and they will give you an email and a phone number so you can contact the program. This is really great. It's called Resident Swap. Um, if you guys can invest in this, that would be great too. I think the 3 months or 4 month fees will be like $100, but they are really good and reliable. And also there is Find a Resident. Me personally, I have never had an experience with Find a Resident. If anyone else has an experience with that, they can like tell us about it. And yes, this is as far as the residency. And I want to remind you guys, this is the perfect time to apply for a fellowship, because a lot of fellowship programs during this time, some of them will have like cancellation, last minute, a lot of people and last minute change their mind. They don't want like work in a specific program. So I would recommend that if you are searching up in Frida for geriatric fellowship, infectious disease fellowship, and nephrology fellowships. So if you have your step 3, of course, that will be a great help, because most of them want step 3. Here's what out there. The process will take time from you, and if you are more than one, like, you can help each other. You can put a long list of all the emails that you found, and also send them a template stating who you are. You don't have to mention your credentials, but mention that you have step 3. You are not a non-visa requiring. You are have like a tremendous experience in telemedicine overseas, and you are interested in their program. Of course, you don't want to mention the specific program name, because you are sending a mass email to a lot of programs. You don't want to get like mixed up and send different name to a different program. So, and just remember, if you are putting all of them, you will not send like 150 emails. You will send one email and put all the email addresses, like the 100 email addresses that you got out of Frida in the BCC, not the CC. BCC, that means blind copy. Like, any of the other program will not know how many other emails you have sent. So copy and paste all of them in BCC and send, and press send. And good luck for everyone. And of course, attach your CV, your resume, your updated resume, and just state anything that you have recently done. Like I'm currently a fellow in Michigan State University doing a telegeriatric research. I have done so and so. I am interested in so and so, and just a brief about them. And a lot of these programs, they are very nice. They can, if the program coordinator or the program director, they will respond to you and they will say, your resume looks great. We love to have you, but we have unfilled position. Can you like contact us in the coming year or something like that? They will have interest in you. And I would like to mention also the importance of connection. Having someone will like help you a lot. If you have someone inside, they will give you a leg up. They can easily relate to you. They can easily know to you. This is like given. We all have challenges. Connection is very important. Working into this connection is very important. From now until you are applying, we have like this is the end of March until next September. We have like 6 months to prepare for the next match. So working up a connection, that will be great. That will be like something you can work on. And best of luck to anybody who is applying for next year. And hopefully you will get a position before next year. And thank you guys so much. If you want a question or anything or a comment.
Okay, thank you so much,
Hi.
Azam. Okay, please go ahead, Krupa.
Yeah, I was just going to say that I just joined the Twitter community recently, but I realized that there is like so much information out there. There are so many IMGs that have not matched, and they're kind of getting together and supporting one another. There's attendings and like people in different specialties that are like posting any kind of openings, postdoc stuff, any like job opportunities. So try to create a Twitter account and get more involved, and you might be able to find some information that way as well.
Yes, thank you so much, Krupa. Yeah, that I heard that too in Twitter. There is a lot of resources over there, and you can easily reach out to program coordinators, program directors. They are posting on Twitter. Thank you, Krupa, so much.
Thank you so much, Azza, for your discussion and discussing the topic, how to reach programs post-match. And also thank you, Krupa, for your input. Selma has a question, though, regarding fellowship training. How does that work regarding having a previous training overseas? Is that considered as an internal medicine residency?
Yes. It's not a residency per se. They will say an equivalent training to residency. They will say that this candidate has an equivalent training to residency. They know, of course, you don't have an MD from overseas, but you are like, you work like 5 years or 3 years or 4 years overseas. That's an equivalent to residency. So yes, they'll definitely consider.
Yeah, I also can add to what Dr. Azza said. Some programs are asking about certificate of training of the specialties that you are applying for a fellowship on, and also they ask also about the summative evaluation of the residency. So if you can provide those from any hospitals with a stamp and a signature of a program director there, or any internal medicine training doctor from overseas, they will be accepted. But it should be stamped and headed with the name of the institute that you did your training, or even if you are working as a general practitioner, but it should be in the institutions that having a residency or training, either in internal medicine or in family medicine. Thank you.
Thank you so much, Mohammed. You're right. But don't let that like stop you from anything. Go ahead and apply, even if you don't know an address or you don't know anybody specifically. If the program is interested in you, contacted you, are the late processes. Like they will do that after you are in, or you are already accepted, or you got the initial acceptance. And don't worry, you can easily get that. Yeah.
Yeah, so you're absolutely right. And also it depends on how many candidates who are applying for these positions, and what the criteria of other competing candidates, if they have these available documents, they will give them the opportunity. But if they don't have this, and they have to fill these positions, so you will be accepted.
Thank you, Azan. Thank you, Dr. Muhammad. Krupa, would you like to add anything?
Yeah, so I was just going to go based on what Dr. Muhammad said. I know a few colleagues that actually, the child fellowship, for example, I'm going to speak on psychiatry, but child and adolescence fellowship this year went unfulfilled. Many of the spots were open. So people who had any home residency back home, like if you had internal medicine, preventive, like any kind of home residency from back home, you could directly apply into the child and adolescent psychiatry fellowship, and they would possibly take you, and then it would be ACGME accredited, and then you would go backwards. So you do fellowship first, and then you do residency. So for anyone that's interested in psychiatry, you're basically going to come out being, fellowship trained, but instead of doing residency and fellowship, you're going to do fellowship first and then residency. And it can be any home residency in any kind of field. They just want someone that has some, at least like a year. Or if you have transitional or prelim year, you can also do that. So if that's the case, like just reach out to any kind of fellowship openings and give it your best shot, because it'll still work out the same way, whether you do residency and fellowship or you do it the other way around.
Thank you so much, Krupa, for this edition. And it's worth trying. You guys don't have anything to lose. It's just an email. Even if they say no, we will not accept. So, and this is like a tight time for all the programs. It's they have to fill the position. They have it, or they have to fill it, or they're gonna lose it. So, like you need to like go for it. Yeah.
Yeah. Also, I can and add an inspiring story. I know a guy who's from Sudan who's also struggling with residency for a couple of years, as like old graduate and low scores, and last year has been accepted into geriatrics fellowship, and he did well. Actually, he's has a great personality, and this year the program director on the March result day on 14th contacted him early, and he said to him, you didn't match, but I am asking you to go directly to the GME office. We offered you a BGY2 positions to work with us in internal medicine.
Thank you, Mohammed. That is truly inspiring. Yeah, there is a lot of good stories about fellowships and a lot of good, I don't want to say old IMGs. Some people say experienced IMGs. They are, when they go into fellowship, they kind of prove themselves and to the system, and they turn out to be a great candidate, an excellent candidate as well for the residency. Thank you so much. Lubaba. Sorry, Sarah, I have taken your role.
No worries.
Hello, everyone, and congratulations for all the people they matched. And for the other people, they're still in the way. I just want to tell you that I am a proof that this thing can happen with persistence and dedication, and hard work will pay off at the end of the day. So I want to add to what Azza mentioned about sending emails and reaching out for fellowships, for open position, and everything that is available for you to improve your CV, regardless. You're going to do the residency in a reciprocal way, doing fellowship first and then coming back. For us, we consider that we did the fellowship. Actually, we're doing research fellowship currently and going back to do the residency. So try to benefit from each opportunity that you will find. It will be an addition to your CV, and it will make your application more strong. I just want to add to the email part. Many of the institute that when the email is coming from unknown kind of email to the institute, it would be directed to the junk if it has an attachment. It's advisable that you send initially an email with your accomplishment and your like big things in your CV and talking about yourself, and then they will be eager to know more and they will ask you to send more documentation. For example, I did this before for fellowship, and they contacted me this way, asking us for like the CV, and so in this form you will make sure that your email will reach the program and they will read it most of the time. The fellowships that really had unfilled position every year, that's infectious diseases, nephrology, and geriatrics. So, and you guys with the Telegeriatric Research Fellowship, I think we have a bigger chance for geriatric fellowship for those who didn't match. Last year I did an interview for geriatric fellowship as well, but it didn't happen. But for a good reason, I am better with residency. So I just want to say that Dr. Mohammed Ibrahim shared a very inspiring story, but I feel like my story myself is inspiring for other people. I've tried this road many years. I don't know how many, but I kept doing it every year. But I feel like that every red flag that people considered in an application, I have it. So I have low scores. I am considered experienced, old graduate, I will say experienced. I do have a gap. I worked for about 3 years as an administrative job in US while I'm doing my master. So I have a gap, clinical gap. I had all of these. I didn't have any research experience until I met Dr. Nader. Thank you so much. I can't thank him enough for the addition that he made. So I just want to say that I am a live proof for people with all the red flags. If you want to have a checklist to take the red flags, you will put me. All of these things I did, and I'm really grateful and thankful for God and everyone that helped me on this road and to make it to a university program that I never dreamed the day that I'm going to join. So I just want you guys don't give up, and this road is really hard. And I had many times that I'm thinking that that's enough. I have to check for plan B and focus on it. Believe me or not, even the day before the results, that I was thinking about what I'm going to do next, because this is my last try. But thanks God it happened. So just keep going and focus on your goal, and you definitely will reach it. So, and I'm really happy to help anyone that he feels like he has questions and any advice. The only thing that I will say that helped me cover the gap for the clinical, that last year I worked hard in adding clinical experience. I noticed that's something lacking or different or distant in my CV. So I gave up like a really good paying job to do like minimal paying kind of clinical experience job. And that's really helped me a lot. So I feel like if you have a gap in CV, just try to prove that you are currently doing something clinical, you understand the system, and you are ready for the residency. Good luck everyone, and I'm really sure that you're gonna make it. If I did, you guys are gonna make it. Thank you.
Thank you.
Mm-hmm.
Thank you, Lubaba. Well done.
Thank you, Lubaba. Your story is really inspiring. It inspires me myself. Thank you so much for sharing it with us. So Sumi, would you like to share anything?
You're welcome. I just forgot, and my personal life too is not an easy one. So I want you guys to feel the whole story. I'm a mother, and I have another challenge too. So I just want you guys to keep really this high spirit and work for it.
Oh, wow, mashallah. You're a woman of steel, mashallah. May Allah bless you and grant you more success.
Guys, thank you.
Okay, so congratulations, Sumi. And would you like to share us your experience with us?
Oh, sure. I'm very emotional to share this experience today, actually. But yeah, last year probably I never think that this day will come to my life. But today it is, and there is my word cannot express my gratitude to the whole team, and of course Dr. Nadir, and especially my other previous year's fellow, Dr. Mulham, Lubaba, Marwa, Ryan, and Khalid, Ali, and so many more. Of course, Aja. They are really great soul, and they helped us a lot to move forward. My special gratitude to Mulham. He basically sit with me. I think he sat with like 1-to-1 and give a specific, feedback and where to work and what kind of things we need to make. As Lubaba mentioned that she has all negative flux and all that, I am exactly the same way. I can tell you that same situation like me. But I tried every year to make my CV stronger and stronger. I would say like I did not work much, probably for the clinical, real clinical training, because my strength was my research, as I am still pursuing, master's degree, and also as well as like I also have a research job in a very good academic university in Michigan. So I would say your red flags are not only the one thing they are going to look, but you always believe yourself, and out of these red flags, everybody has their like so many positive and so many I would say green flag in your CV. Just believe yourself, because I have, as Lubaba said, like I cannot change my graduation year, I cannot change my scores, But what I can change is, like I can have more like, paper, or like I can make contacts, and I can do something very different or unique, which I will be outlier candidate compared to others. And see, I matched into a program which everybody here probably knows already, where I was doing my vaccine hesitancy program. So I do not have any, when this program I was posted in that program, they do not take much foreign graduate. And by knowing that, but it's my master's program where I have to do this project in that program, and I came to know that they do not take much foreign graduate. Probably I will be the first one or second person who got accepted for that program. And as like everybody is very, very fresh graduate, it's like they're all like either Caribbean graduates or American graduates. But with these difficulties, and then when I talked initially to the program, they say we usually don't accept foreign graduate. However, you work with us and we'll see how it goes and then decide. And yesterday I got an email from the GME director that when I say that thank you for believing me and giving me this opportunity, I wish that I can show you that email. And they said like, we are very fortunate to have you in our program, and you achieved it. It's not like you impress us, that's how you achieved it. So why I'm sharing this story, because try to make an I think it's always better you make an impact to the program rather than program know you through someone. It's possible. And as Lubaba mentioned, I'm a living example for that it's possible. Same thing I also thought 2 days before the match, that like this is my last try. I do not have any other things to add in my CV, as I'm done with masters. I have more than 25 publications, and then I have a research job. So I have to move forward with my plan B. And unfortunately I cannot, I'm very limited because I cannot move much with my family situation and all that. But also I want to say that I know that here there are a lot of mothers here, and I want to cheer up for all of you that I did my all exams with my daughter. And I think this success is for with like all of them. My family also sacrificed a lot, but because of these days. And anyone like who is a foreign graduate or very old graduate, please do not lose your hope. I can guarantee you, if you are persistent, if you are dedicated, and your days will come. It is just only the time, today or tomorrow. But like it is not only the score, it is not only the graduation year the program look. They also when I was interviewed, they also look your personality, how you communicate with people, how you communicate with your peers, how will you communicate with patients. So those skills are very, very important. Please do not like give up. Oh, okay, I do not have this score, I'm not eligible. No, I think whatever, everybody has some positive things, everybody has some negative things. If you recognize your negative things, or if your peers even give you some feedback about the negative things, work on that, and I can guarantee you everyone will succeed today or tomorrow. I'm ready to help to anyone. All of who did not match today, I was in your shoe not too long ago. I completely understand your situation, and that's why I want to help you, all of you. And also thank you so much, Lubaba and Sarah, for this year who practiced interview with me. And that gave me so much, I was very confident during the interview. And two things I always want to mention about this whole process, that of course believe in yourself, but as Lubaba mentioned, I think, or whoever mentioned, like reaching to someone, and if you may do like 500 email a day or something like that, but you need you do not expect that people will respond. But if 1 or 2 people respond, that's all you need. And same, like you don't need to go for 10 or 12 interviews or whatever. You need only 1 interview to match. So like I know people will talk about 4 interviews, 6 interview, whatever, but it does not matter about the number of interviews and number of red flags and all that. But it's all matters how you are, or how you can represent yourself as a person whole, as a whole. I heard from from one of the faculty who interviewed me that, like basically they are saying, like, when patient comes to you, they are not going to ask like, hey, when did you graduate? Because my graduation year was a very red flag for that program where I matched. It basically, like your personality, what tells you that how compassionate or how empathetic you are with your patient. So, I learned from them. I learned from these things from all of you. And again, my sincere gratitude and thank you for Dr. Nadir. I have learned also so many things from him, like, how to communicate with your, like training and whatnot, because as a mentor, he is an excellent mentor. If you reach out to him, he will make sure that he will reach out to you in 24 hours. So I know that is a big lesson for all of us moving forward, because you will be someone's mentor tomorrow. So that's a things. But if anybody needs anything, you can definitely contact me for any help. I just want to add one more thing, as every one of you, as Lubaba mentioned about the fellowship. They all mention about infectious disease and I guess a geriatric and nephrology fellowship, but also there are some fellowship who is interested in neurology. If I'm not wrong, probably Dr. Avinash was interested about neurology, or if any one of you are, but there is a research fellowship even in One State University, which is called like a multiple sclerosis fellowship. They do accept a lot of foreign graduate like our background, and also they if you have a experience in neurology back home or here, like a research experience, and there is a big chance that you might get that fellowship and followed by residency. Whoever match or whoever got the fellowship, multiple sclerosis fellowship, everyone match for that program. I was interviewed for that program a couple of years ago, but unfortunately at that time I did not have any experience from back home or here for neurology. So that's why probably they did not accept me. But in that time, if I had a little bit of experience, it was, I heard that people have people like whoever did a fellowship there, all of them match for the residency program. So there are some fellowship for neurology as well. And thank you all and good luck.
Thank you so much, Sumi, for all the details and the inspiration and the advices. We appreciate that, and actually I'm happy you matched. I'm happy we all matched, and for all our colleagues, your hard work will pay off, inshallah, very, very soon. I would like just to mention like a few tips from my side myself. This year is my 4th year applying for the match. It was like, and last year I almost had a heart attack on the match day, and I didn't know what to do, or like I was very, very confused because I thought I did all the things that I should be doing. What the difference that made a difference for me, first of all, I went to ask my colleagues who went ahead of me and matched, even like matched on that year, to figure out what was my problem is. So I believe that seeking mentorship and asking advice from everyone, and regardless how you think it might be trivial or unnecessary, it makes the whole difference in the whole equation itself. Also, the thing that I had like I have very low scores, and also I was very insecure about that. And usually, like in the interviews I had in the previous 3 years, they usually highlight that in the interviews, like you have low scores, you are an IMG, you are an old grad, and about the idea of being aware of your positive and your main strength points makes the whole difference. I'm an IMG, but I have the cultural sensitivity, and I can work with multiple people from different backgrounds. I have multiple languages. I can speak in Arabic, and we have an Arabic population that with different backgrounds, and understand their needs. I can speak in English. I have this brings me the flexibility to be able to deal with different patients. Okay, being an old grad gave me the experience, different experience from my home country, being working in underserved areas with limited resources, and we have to work on a fast pace. So I bring that with me. Being aware, like not just like don't allow yourself to be entitled by anything you assume it's a red flag. You can convert every red flag you have into a strength point, and don't let that you shy down. Last year I reached for so many programs, so many people since April last year, just sending them my application and highlighting my strength point rather than being insecure about my weak points. And actually this year, because I am because I highlighted my strength point, very rarely, very few just mention my weak points. Okay, so self-advocate for yourself. Don't let anybody put you down. Don't let your red flags limit you up. I almost lost faith about my match this time, but just like I had to do what I had to do. Like I had no other choice, and alhamdulillah, I matched this year because I didn't allow myself, I didn't let myself down. I didn't allow my red flags to define me, rather than just a stepping stone or just like a hump, something like, like you scrambled your legs and just you stood up again. Okay, is you continue on and go on, you learned your lessons, you grew out through the experience of getting yourself up again, and now you are stronger than you think you're stronger than you started, and inshallah everyone will match and everyone will make it. Also, as I agree with what Krupa said, like the Twitter community is so reinforcing and encouraging and uplifting. There's no like kind of people like reach out for me. Like once I made the Twitter account, just I shared that I didn't match last year, and so many people reach out to me. Okay, you can do that, you can do that, reach this person. People just were very initiative and very positive, and just like they came volunteered even to give me hand. So I totally agree that Twitter community is so reinforcing and so encouraging, and a very, very positive community there, gives you solutions to problems, not just like drowning in a helpless situation. Also, through Twitter, I was able to attend like multiple open houses, and attending the open houses like since July, August, and September made a whole difference as well. Like I attend the open house, I take notes of what they say, and then I send them an email. What I like 1, 2, 3, 4 about what I learned from the open house, and actually that helped also with me this year, because this was an opportunity to establish connections with the program without even having to know anyone. Even I searched for the residents who attended over LinkedIn, and I asked them questions about the program and asked them if they can give a word for me. And some of them actually were very helpful and very supportive. And actually they gave a word for me to the program, and they helped me to get an interview as well. Also connections, I cannot stress enough, even if you have friends who match there in any program, just don't hesitate about that. Like make sure that you are the person, reach your friends, reach your colleagues, reach your far friends, reach everyone you know. Even if they have a low probability, they will help. You will not lose anything, except like you are asking them a few questions about the program, and you are applying for the match, and you have the credentials, all the necessary credentials for you to be a resident there. Also, this is very, very helpful. Again, my 2 cents for you: don't let any red flags define you. Don't be entitled. Don't let yourself down before anyone else, and put in your eyes, put in front of yourself what are your actual strength points, and go from there. Don't hesitate for you have these weak points. Okay, you learned, we have our human nature, and we do our mistakes, but what matters the most is that we learn from our mistakes, and we don't define ourselves with our mistakes. So congratulations to everyone, and good luck for everyone in the next chapters. And inshallah, we will all match, and like today, next year, inshallah, or maybe sooner, we'll be celebrating our match together, inshallah. Thank you all.
Thank you so much, Sarah. Well said. Thank you.
Thanks. Okay, so is there anyone who would like to share their match experiences to provide like insight to everyone?
Hi, Sarah.
Hi, Sarah. Congratulations.
Yeah. Thank you very much, and congratulations for you, Lubaba, Sumi, and all the other fellows who matched. Like you said everything, you, Lubaba, Sumi, I can't add anything. I just want to thank Dr. Nadir for all the help he provided to us, and really this fellowship, we learned a lot. It's not only about something you write in your CV. Excuse my background. It's not about only something you write it in your CV or just get a letter. I felt that I really improved during this 2 hours weekly. I've learned a lot through even the sessions, the research, doing posters, interview skills, everything. Really, the schedule is well made, and it looks like it's only 2 hours a week, but actually we benefit a lot through this 2 hours. Thank you, Dr. Nadir. Thank you for the team. I really wish this great work continue, and I feel that we should pay back for this fellowship, definitely, and we'll be here helping the next year, generations, even after we finish our residency. Hopefully, we should help others. And this is the message I got from this fellowship, all the dedication, every weekend on Saturday, Dr. Nadir is here. We sometimes miss the meeting, but he never did it. And this really reflects the enthusiasm and how he cares about all of us as applying for this residency. So this is the thing that we should focus in and just highlight, that to help others. It's a great message and we should take it with us. I'm here if anyone needs help. Maybe my story is not as inspiring as the other people. I only moved to the US 18 months ago, maybe less. I was working in Ireland for 6 years. I was working in Sudan back home for 2 years. Before that, I am old grad. But what I want to stress from my background, that every clinical experience, wherever it is, count. Because in my experience, say, all my interviewers were asking me about how I did go to Ireland, why I did go there. And they were saying, oh, this is a very rich experience. I felt that they were kind of confident of my clinical knowledge and experience, that from working there and having the letter from there, that I have the enough clinical experience. So they were not doubting. They just want to know my personality and other stuff and why I'm coming to the state and my commitment to the state. So do not worry that you have to come to the state, even finishing your exams, if you have this privilege. I know a lot of you have families here and they are already here in the state. I'm just telling the other people who are in Sudan or in other countries that take any opportunity. And even if you're planning to come to the US at the end, do not waste your time. Say, just come to the US without having a specific plan. If you have a place you can go, you can get a registration in UK, in Ireland, you work in Saudi Arabia or wherever, every clinical experience counts, and all the letters from outside the US still they are count, specifically if they are coming from attending with high training, and they're from institutions, larger institutions and so on. My other advice would be, I know the fellows here, most of them already done the exam. Do the exams as fast as possible. Do not hesitate to study hard and get your exam fast, and apply for residency as soon as possible. Every year you lose it, just studying, wasting your time because you are worried that you will not get the score. It's going to be counted on you. So the faster you apply, the better. My last advice would be, during interviews, I would say be genuine and be yourself. Show them who you are in reality. And I know everyone would have something unique about them, about their story, about their journey. Try to make the best to present yourself, your real self, in the interviews. And rather than just prepare for the interview being a robot, prepared answers. You just come to you need to prepare for some tricky questions like your strengths and your weaknesses or whatever. When they ask you to talk about yourself, just put a bullet points rather than just save an answers, and just because a lot of people do this, and this is what will make you different and standing out in the interviews. They should remember you, like make it a conversation that they can remember through just talking from your heart, telling true stories. If you do not have exciting story, do not make one. You don't need to. We are all like human, and we live like some of us have just normal life. They have never come across difficulties or whatever. I remember my husband is a physician here. He helped me a lot. I'm really grateful for his support. So when I was making my personal statement, I was like, no, I don't have anything exciting in my life. I should tell some like story or something. And he kept telling me, no, you don't need to. Just be honest, and honesty is the key during this application. And he was helping me making like my personal statement, and like when we were like writing it, I found out it's really interesting. I have some interesting things in my life actually that I wasn't thinking they are interesting. So at the end of the day, it was a nice. It wasn't something that I would say there's something that exciting or whatever. I just told them that I live between 4 different continents. That was my personal statement. Like I was born in Sudan, lived in Saudi Arabia, then lived in Ireland, and then I moved to the United States. I never looked to it this way, except the day I wrote my personal statement. And surprisingly, all of them were like excited about this and telling me, oh, you moved a lot around the globe, and tell us about this. And that's it. Like just my final advice would be just work hard. Like the last 2 years in my life, I was like, I did my exams. I was like, I have a new baby. She's 8 months old. Like I remember I've never been so busy in my life. And I'm really proud how I am improved in the last 2 years. And every minute that I was working hard, it did count. And it will be obvious on you. You will improve a lot. So the harder you work, you will definitely get the result. You might not get them soon, but you will get them finally, inshallah. And I hope the best for everyone. Congratulations for those who match, and for those who didn't match, just believe in yourself. It's not defining you, and just work hard again, and you will get them finally. And thank you, everyone. And lastly, thank you, Dr. Nadir, again. Thank you, everyone.
Thank you so much, Sarah, and congratulations on the baby, and congratulations on the match. It's very well said. Thank you so much. So is there anyone who will have a question or would like to share their input or the experiences?
I just have a suggestion, Dr. Sarah, for those who have been matched this year. If they can write down their stories in detail for the rest of the fellows who didn't match, just to inspire them and to help them to find as a guide to them for the future application seasons and also for the future fellows. Thank you.
Well, thank you, Dr. Muhammad, for that. That's a good idea. So thank you so much for sharing that with us. Thank you. So finally, I would like to thank Dr. Nader for all his efforts with us, and through the fellowship, I myself wasn't able to do anything like as much as I did in last year, like being part of conferences that are well known, having as many publications, the interview preparation, his advice and how to improve ourselves, how to be better. He was very there for for me and everyone, like supporting us with advice, for mentorship. If anybody needs help, he is never late for us. So thank you so much, Dr. Nader, for your help, for your efforts, and for this wonderful opportunity to be one of your students, and your students like learning and inspired by you. So thank you so much, Dr. Nader. I appreciate that so much.
Thank you. Thank you, Sarah, and thank you, the other Sarah, Lubaba, Sumi, and all the rest. And thank you, Avinash and Aza. I think I'm the happiest person in this group now, and in the world actually, because I think I just heard the most wonderful news of all of you, those who match and those who are going to match, inshallah. Hopefully soon, if not, maybe next year. So I wish all the best for all of you. It's just like chapters. You finished one chapter now, you're gonna start a new chapter. For those who match, for those who did not, you are still in one chapter. Hopefully you will finish this chapter soon. So thank you for the tips and sharing your experience, guys. This is wonderful. I think it's very helpful tips and tricks, if you may. So if anyone wants to reach out to me for any additional help, I'll be happy to assist as much. And once again, congratulations to all of you. Thank you.
Thank you so much, Dr. Nader. Okay, so is there anyone who would like to give an input, or shall we move on with the next section or agenda?
For thank you, Kropa, also for adding the psych fellowship, because we focus only on the geriatric, and then, as I mentioned, the other fellowship opportunities like GI or infectious disease. I think many of the fellowships, they want to fill their positions. If they don't, unfortunately, for 3 years, if they have opening, the government will take those positions away. And if they left out with one position, the program will close. So many programs actually closed because of this problem. So for those who didn't match, I would advise you, if you have time, to go to Farida and go to the list of your jobs, the program fellowship. Let's say, for example, geriatrics, go over the geriatric programs. I think there are 150. Look at them, see, select those who, if you don't have problem with visa, then you don't have to mention that. If you need visa, then you select the program that offer visa, so the list will be shorter. And then go to the requirement. Some of them might have an opening still now, so these ones will be on your list. The one who says we don't have any offering, any open positions, then you will remove this from your list. So out of the 150, maybe you will end up with 50 or 40 good programs for you in the area, for example, geriatric. So if you can contact the program coordinator for this fellowship, just highlight the same areas where Lubaba and Sarah and the rest mentioned, that you graduated and you have whatever skills you have, research skills, leadership skills, presentation, clinical skill if you have. If you are going to send it an email, I would advise maybe a paragraph, not more than 10 sentences, where you will concentrate all your highlight points in that section. And then on the title, also put 4 or 5, maybe 6 keywords where you are excellent, attractive candidate for them to be looked at your CV. You don't have to send your CV, but if you summarize it in the 10 lines paragraph or less, that would be great. Because if they want to open the email, they will look at the title of or the subject title of the email, and you have a limited area. So you want to highlight, if you don't need a visa, then you say citizen, US citizen, or you have a green card, and then you have clinical experience if you have clinical experience, and then you have research experience, excellent research experience at MSU, something like that in the subject line. And then you can put some of the details, but with highlight keywords in your paragraph. So I think that's how you can approach the whatever, let's say 40 or 30 programs in fellowship in geriatric. And you can do the same for the residency programs in internal medicine, family medicine, or other, for example, neurology, pathology, or psych. You can highlight your experiences in the area where they match for that specialty. And then you can add one last line that you are interested in visiting their program. If you want to add one more line, you can add that you are interested in joining them next year. So you will have the last sentence that you are interested in their program for next year. But if you want to start, you can start, I'm available right away. If you want to start your email with that, or in the title that available candidate for the residency, for instance. Just in case they have an opening, you will be looked at, and they will look at your email, and then maybe they can contact you for your full CV, your ERAS application, and the rest, if you have review, letter of references and so forth. So this might just 2 cents, they say. And I wish you all the best, guys. Thank you, everyone.
Thank you, Dr. Nader. This is valuable advice. Thank you so much. Also, I would like to add, in terms for emails, I would suggest that we send letters of email of interest during the match season till the very end, because some people said, okay, they are done with interviews by November during the last match. But actually, what happened, I sent Happy New Year email to some of the programs in January, and actually they kept sending invitations, because during the last month of the season, many people cancel their interviews, and they are not in the best shape. They want to fill that spot. When you send them just an email out of courtesy for the new year, despite the stress of the match season, they put that into consideration. And actually, this don't believe the rumors that say that interviews are done in November or December or anything like that. Keep sending letters of interest till the end, till January, till even up to mid-January, and you actually will be surprised by some programs might respond to you and send you an invitation for interviews. So this is another thing that helped me this year as well. Okay, so is there anyone who would like to share an input, or shall we move on with the next section in the agenda?
I wrote in the chat, I just want to add, sometimes when you put something catchy in the subject line, and open the email. So I found this when I put MSU, at least there is a response. Sorry, we filled our position, but we welcome you to apply next year. Stuff like that. Always catch their attention. That is MSU is really big thing. Thank you so much, Dr. Nader. Whenever we write MSU, we remember that's all of your effort with us. But try to put something catchy and mention MSU in it in the subject line.
I totally agree with you, Lubaba. As well, I use a different subject line. You just wrote my name and letter of interest or interest in the program, and that's it. And during the ranking, I send them like the programs that I had interviewed, just as well my name and letter of intent, just something related to what we are doing, related to the season, and no much details. Also, there's something called an application called Boomerang, BOOMRENG. I would like to. It helps to schedule the emails to send them like at a certain time at 8:30 or 9 a.m. in the morning. So it gives me the flexibility to write the emails according to my schedule, before I sleep, at night, in the evening, according to how the day goes. But I schedule it through Boomerang. Also, the Gmail now is providing this free feature to schedule the email itself. But the good thing about Boomerang that I can schedule resending the email like on automated form. Like if it doesn't reply, maybe repeat the email in 10 days or in 2 weeks or something like that. So that like the headache of having to write an email and a follow-up email for every program throughout the season, just it eases the effort maybe by 50% or something like that. But I didn't know about the trick of the BCC. I've learned about it today. So thank you, Azza, for sharing that with us.
And thank you for sharing the feature for the Gmail. I'm always back on my emails. I just want to mention that what I meant for reaching out for fellowships. Yeah, for the season, it was different kind of subject line. Like regarding the residency itself, letter of intent and letter of interest as well. This was different, but for the fellowships, if they know that you are already doing a fellowship or you finish a fellowship, that it's an exceptional thing that they can argue with the GME about.
Oh, got it. Thank you for clarifying that. Thanks a lot.
You're welcome.
I'd like to add one more feature or trick I used in the past, and maybe one of you or some of you might use. Beside the email, there is electronic fax. There are a couple of options. One of them, e-fax, is like sending the email, but it will end up at the fax machine for the program. There are many companies online that they can do that. So you can just upload your letter and it will be sent as a fax. Some programs you can download and you can use them in your computer. But the idea is in Frida, they have, some of the program have their fax numbers. So it's another way to reach out to the program of interest for you. So let's say I'm interested in MSU internal medicine. So I will find their fax number and then I will get an account with eFax or other services online. Maybe it will cost you $10, $20, maybe $50 a year. So you can just create the account and then put the fax number for MSU, and then you can, it's like attaching your letter. It's gonna be just the first page, and you can send it to the program, and you can send as much as you want to other programs and see. That's another way of catching their attention, because emails sometimes they go to the junk mail, but with the fax, mostly it will be read by the program coordinator at least, and if they have opening, you might be on the spot for them. They may find a solution right away. It's just a trick. Thank you.
Thank you so much, Dr. Ned. It's definitely like a new idea. I'm learning today as well. Thank you. Thanks a lot. Also, just I would like to add just another something. The website acgme.org. It has all the emails, the contact emails for the program director, the program coordinators. Sometimes, like, they share on Freda a single coordinator, but maybe they are multiple, or maybe they are transitioning. So also the website, this website has all the information, just like acgme.org. And then we press Search Institute. And then after that, just you type either through the the ACM, the ID number, and it brings the program and all the details about the program directors, their phone numbers, the program coordinators, because it's not easily found on or like in different websites, sometimes not on ERAS or Residency Explorer. So also it helps to reach out to the program directors directly. Okay, so thank you so much for your inputs, everyone, and congratulations one more time. And hope everyone reaches and fulfills their goals and their achievements. And we hope we all have more success in our next chapters and make it all together. So is there any suggestions we can do next, or or should we move on with the agenda or prepare for next time's agenda, or what do you suggest? Okay, so Dr. Nader, okay, so let's move on with the agenda for today. Okay, thank you. Okay, so the next part is the presentation is made by Dr. Ala Abdulsamad. It will be a quick refresher on the basics of evidence-based medicine, but I will be doing the speaking part, but it's all her presentation or all her work. So allow me to share the screen. Okay. So can you see my screen?
Yes.
Okay, sounds good. Thank you. So we are just reviewing quickly the basics of evidence-based medicine. So what is the evidence-based medicine? It's the integration of best research evidence with clinical expertise and patient values. So it's an intersection between the best evidence of practice and the clinical experience and the patient values, putting together to allow to reach the best outcome based on evidence for patient care. So what is evidence? So evidence is its findings from the patient-centered clinical research that are relevant and valuable to patient care. And these are systematic review and meta-analysis, applied research from the labs, and experimental and observational studies. The clinical expertise is the insight and the intuition acquired by a seasoned clinician, by an experienced clinician through extensive interactions with patients and seeing the outcomes obtained from various interventions. While the clinical circumstances are the setting in which care is provided, such as primary care facilities, urgent care centers, hospital emergency departments, hospice care, home care, and so on. What are the patient values and preferences? So these are the subjective beliefs and attitudes and the cultural backgrounds and the spiritual factors that are related to healthcare choices, which is the whole idea of the patient-centered care model. Without this input from patients about their beliefs and desires, the clinician runs the risk of doing harm rather than benefit for the patients. And we want to avoid that. So what are the 5 steps in practicing evidence-based medicine? It had the mnemonic of 5 A's. Ask a question, ask a clinical and relevant question that has an answer. Acquire the most relevant and the best evidence to answer this question. And critically appraise the evidence for the validity, the relevance, and the applicability. Apply the evidence along with the critical experience and patient's preferences and values, and assess the effectiveness and efficiency of the application of evidence, and assess the ability to ask and acquire and appraise more in order to improve the whole process one more time. So in details, asking an answerable question. So we follow the PICO format. What's the patient or population? What are the interventions we are asking? What are the comparators, and what is the outcomes we are looking for? For example, there is an example that's not following the PICO format, what's the best treatment for heart failure? But if we dissect our evidence we are looking for, it will be what's the population? To be the elderly with systolic heart failure. What's the intervention? It will be ACE inhibitor use. What's the comparator? the placebo, and what's the outcome we're looking for is the reduced mortality. So in elderly patients with systolic heart failure, do ACE inhibitors reduce mortality in comparison to placebo? So now we are more focused and seeing more relevant evidence just by following the PICO format. There are other concerning questions, such as the clinical evidence, how to gather clinical findings properly and interpret them, how to select and interpret diagnostic tests for diagnosis, how to anticipate the patient's likely course, such as the prognosis, how to select treatments and do more good, do benefit than harm. And this is the most important question, is why, and this is the relevance of the whole evidence-based practice is for therapy, and how to screen and reduce the risk of the disease for prevention, and how to teach yourself and the patient and the family what is needed for terms for education. How can we acquire the evidence? This is the next step. We usually use secondary resources such as PubMed, Embase, Cochrane Library, Google Scholars. We can use textbooks, and also we use the validity filters to narrow down the results. Third step is appraise the evidence. In terms for validity, we want to look for good quality studies that are well designed with a good impact. Impact means size of the effect or the benefit, or is there any clear or useful plan of action, and is it applicable, can be applied to the patient or to the population, the target patient or target population or not. And this is like a hierarchy of evidence, and as we see like in the base, so there's like the ideas, the opinions, the reviews, has the lowest quality of evidence and highest risk of bias. But as we climb up to the peak of the pyramid, we reach the systematic reviews and the meta-analysis, and this is why it's like highly respected in the medical and clinical community, because it has the highest quality of evidence and the lowest risk of bias. And steps 4 and 5, applying and assessing the evidence, like it involves applying the collected evidence to facilitate patient care, to collect the factors to consider when applying the evidence, the external validity, the clinical versus the statistical significance, the patient's goals, desires, and values, and the assessment that involves evaluation of the patient after applying the evidence-based decision. So here's just a quick summary of what's the points about the evidence-based medicine. All evidence is not alike. Some is better than other. When the doctors look at the research before like recommending a treatment, they're using evidence-based medicine. So evidence-based medicine looks at the research that's about the disease or treatment. When researchers look at whether a treatment works, they just look at so many patients and the results of so many patients, not just a single doctor treating a single patient. Sometimes the evidence cannot tell which treatment is best, but it's important to weigh up the benefits versus the harms of the intervention we are studying or looking forward into. What are the limitations of the evidence-based medicine? It's time consuming, it requires access to medical literature, requires some knowledge and awareness of the statistics. There's, of course, the publication bias and the conflicts of interest. And that's it, and thank you so much. And I will pause the sharing. Okay. So is there any anyone who has questions or would like to add something to the evidence-based medicine and the concepts? Okay, so awesome. Okay, so with that, I feel that someone is trying to say something, but I cannot get it. So please go ahead. Okay. So the next section in the agenda was sharing the experiences about the match experiences, and so I think we've covered that in the discussions, in the previous discussions, and I believe that Okay, so the next step in the agenda, we should be like planning for the next week's agenda. If nobody has any input or any questions, the red team should be moderating the presentation for the next week, inshallah. So is there anybody who has any suggestions for the next week? Okay, and so just a quick heads up about the project and the progress in the projects. So my project on the echocardiographic findings of the second dose of mRNA vaccine has been submitted to the ECC, American College of Cardiology. And inshallah it will be presented, and then from the conference will be held from April the 2nd and the 4th, inshallah. It will be as a poster presentation, and we've submitted that. And thank you so much, Dr. Nadir, for your feedback and your improvement in the presentation and the poster. Thank you so much. Also, the other one about the CT results that has been also submitted. Lina, would you like to share your input about that? Lina Al-Atta?
Hello, Sarah. Hello, everyone.
Hi. Hello.
Hi. Yes, our poster presentation also will be held from the April 2nd to April 4th on the cardiac MRI results after the second dose of mRNA vaccine. We submitted as poster presentation, and I would like to thank Dr. Nadir for his feedback. Thank you, Doctor.
Thank you both, Lina and Sarah, and your team. I think this is great news, and good luck with the presentation. Is it gonna be virtual, or are you gonna be actually in the inside?
Okay, so because of the COVID restrictions, they are allowing us for the option to do the virtual presentation, and this is what we chose to do.
Is it gonna be like pre-recorded, like you record and then submit video?
It's optional. It's optional, and we recorded that. For my presentation, I recorded the audio part of it.
Excellent. And how about Lina and your team?
Actually, I didn't record. I ran out of the time, but I submitted as a poster, virtual poster. Yes.
No worries. I asked because I want to keep track, and we want to keep also copy here so that we can show the next fellows how we did and how they can do it in the future, the presentation if it's virtual. Thank you so much.
Inshallah. Thank you so much, Dr. Nadir. I appreciate that. Thanks a lot. Okay. So is there anyone who would like to share their input, their progress in the researches or projects? Okay, with that, so I think we are done for the agenda for today. And thank you so much, Dr. Nader, for all your efforts and support over the past year. And on the behalf of the Brown team and everyone, thank you so much for attending with us today. And congratulations for everyone who matched. And inshallah, everyone will reach their goals. Inshallah, just keep the hard work, everyone. And thank you, Azza, for volunteering and helping us today with the presentation. Thank you so much. And again, thanks, Dr. Nader.
Thank you. Thank you so much, Sarah, for moving on with the agenda for this meeting and taking care of business. Thank you, everyone, for attending, and for those who will come later. We wish you all the best, and for those who won or matched, congratulations. We are happy for you. And for anyone, if you want to reach me, I'll be happy to be in contact with you for any questions that you have or any project proposal ideas and the steps to improve in the coming days, weeks, and months. Thank you, everyone. have a wonderful day or night. Assalamu alaikum. See you next week.
Inshallah. Thank you, Dr. Naja. Assalamu alaikum.
Assalamu alaikum. Thank you so much.
Walaikum salam. Thank you.
Enjoy the rest of your week, everyone.
Thank you.
Thank you, everyone. Have a great
Thank you.
night.
Bye-bye.
Bye-bye.
Thank you, everyone.
Thank you.